Okay, good evening everybody, and welcome to this UKFPO webinar to discuss the new UKFPO Foundation Programme curriculum. That's the 2021 curriculum. My name is Fiona Cameron. I'm chair of the Academy Medical Royal College's Assessment Working Group, and I'm presenting this webinar on behalf of the UKFPO and also Dr. Tony Choules, who is the chair of the Foundation group within the Academy of Medical Royal Colleges. So I'm going to discuss, this is for supervisors, clinical supervisors, education supervisors and any trainers who are involved in the Foundation programme. Thank you very much for joining. Next slide, please. I think the important thing to discuss at the beginning is what's the purpose of Foundation, and that is very much described within the new curriculum. So the Foundation programme is part of the continuum of medical education. We start with the undergraduates, and at the end we have Foundation doctors who are ready for either specialist or GP training. Foundation copes with several transition points. The transition point from being an undergraduate into postgraduate training, and then achieving full GMC registration and going into F2 training, at which point they receive their certificate of completion and then are eligible to go into whatever specialty they wish to do so. So I think the important thing to remember is that this is an important transition point for Foundation doctors. There are high stakes transition points, and it's very general. This is generic training. This is not specific to one programme in specialty training or another. It is generic training. The trainees are ready for any specialty that they may want to enter following Foundation. Next slide, please. What's important to remember is that we're trying to train these doctors to be 21st century doctors. They can't store everything in their heads. They must evolve, and medicine evolves, and the Foundation programme has had to evolve with the change in practice. Well, as you know, we're required to follow the requirements of the GMC, and the GMC have created, as you know, general professional capabilities. The Foundation curriculum is based on the general professional capabilities, but within Foundation we call them Foundation professional capabilities. This curriculum and its assessment strategy has been through a very long process. We have had many stakeholder events. All 4 nations have contributed. We've had feedback through the Academy of Medical Royal Colleges, through the trainee rep groups, lay groups, consultants, GPs. Multiple colleges have contributed to this curriculum. And we've had a lot of trainee involvement. We've very much listened to what the trainees have told us, and we've listened to what the GMC have asked us to do. What they have asked to do is to simplify it, make it relevant, make it pragmatic. And first of all, we decided to think about what is the role of the doctor and what is the role of the Foundation doctor. Next slide, please. With that in mind, we have divided it into 3 sections. First of all, what is the aim of the Foundation curriculum? How do we approach delivering the curriculum? And how are we going to assess the trainees' performance in obtaining that curriculum? So these are the 3 things. What are we going to do? How are we going to do it, and how are we going to assess it? And the curriculum is broken down into those 3 areas. Next slide, please. Let's start with the aims of the curriculum. Next slide, please. So we look at what the outcomes of the Foundation doctors will look like at the end of their Foundation training. We consider Foundation training as spiral learning. So they don't follow a different curriculum in F1 and F2, they follow the same curriculum. However, they will be expected to have different behaviours at their F1 stage than they have in their F2 stages. And the curriculum clearly documents the behaviours expected of an F1 doctor and the behaviours expected of an F2 doctor. So let's see what those outcomes are. So in the previous curriculum, we had 4 sections. In this, we have 3 higher level outcomes. Looking at each of these in turn, starting with HLO1, the clinician. So HLO1 is where we expect the foundation doctor to be an accountable, capable and compassionate clinician. This is essentially what they're doing on a day-to-day basis, whether it's in primary care, secondary care, in community or in a tertiary centre. We're expecting them to behave as a clinician. HLO2 is recognising that they are a worker. They're a valuable member of the healthcare team. They're not in a placement. They're not supernumerary. They are not on a placement. They're actually part of the team. And HLO3 is the doctor as a professional. What we like to do is prepare them for the future. We are preparing them to develop their portfolio, to be lifelong learners, to recognise where their development needs are, and to contribute to their own development and other people's development. And some of these are new in that we haven't actually formally assessed them before, but we're going to assess each of these HLOs. Underpinning each of those HLOs, we have foundation and professional capabilities. Next slide, please. And underneath these HLOs, we have these 13 professional capabilities. In the previous curriculum, we had 20 FPCs. Now we've cut that down to 13 FPCs. And underpinning each of these HLOs, we have specified which of the FPCs link directly to the HLO. Now, I'm not going to read them out to you because you can clearly see that, but HLO1 refers very much to the doctor as a clinician. So we're looking very much for evidence linked to assessment of the patient, prioritisation, planning, not just for the physical condition, but the mental health aspects of it and the social aspect. We're thinking about the communication with the patient, with the family, with all the stakeholders and the multidisciplinary team, and thinking about where they fit within that patient's journey. So what we are looking for is the trainee to provide evidence of learning linked to the FPCs that will evidence the HLOs. As you can see, each of the HLOs has very specific FPCs. And when you look at the curriculum, underpinning each of these FPCs, there are a series of behaviours. Now, these behaviours are there for the trainee to think about why they might want to, and what evidence they might want to upload, and are helpful for the supervisor to suggest to the trainees what they might want to upload. Next slide, please. So this is an example of what you might see when you look into the FPC, and this is an example for FPC 8, which is upholding values. As you can see, FPC 8 acts as a responsible employee, including speaking up when others do not act in accordance with the values of the healthcare system. So underpinning that, we have behaviours that an F1 and an F2 might want to provide evidence towards. So you might think about perhaps looking at maybe an M&M report or DATEX or medical error at an F2 level. So these are not absolutes, these are suggestions, and these are guides as to how you might think about evidencing these behaviours. It'll be helpful for supervisors when they're assessing their trainee. If they're not sure if they've uploaded the correct evidence or the evidence is relevant, they can have a look at these behaviours, see whether they map to the FPCs, and then decide whether they're suitable evidence for sign-off of the HLOs. Next slide, please. Now, as I said earlier on, the foundation curriculum is preparing doctors for the 21st century. Unlike previous curricula, where we have commented on and expected evidence of mental health and social health, the 2021 curriculum is very specific, and it focuses on the parity of physical health, mental health, and how that interacts with the patient's social health and social environment. And all throughout the curriculum, there is specific mention to the parity of physical and mental health conditions. We're expecting trainees to work in all settings. We're expecting them to work in the acute setting, and that is also acute mental health care setting. We're expecting them to manage in community settings, and we're managing acute and chronic illnesses. Again, this is a very general training and outcomes based. Next slide, please. Let's think about how we're going to approach that. Next slide, please, Claire. So as supervisors, the curriculum is very specific about how we support the foundation doctors. The foundation curriculum emphasises this very specifically. We all know that foundation doctors are very inexperienced when they start, particularly in F1. They also need some help when they move up from the F1 to F2 grade, which then also can be quite a significant jump for them. As you know, foundation doctors come from varied backgrounds with a wide variety of needs and requirements. And the supervisors have to be very clear that every doctor is treated fairly and that any adjustments and requirements are available to all doctors from all backgrounds. And we understand that many doctors coming from out with the UK are not familiar with the UK training system, and therefore these doctors, who are incredibly valuable to us, need additional support and training to understand how the UK health service runs, how the curriculum runs, and maybe requiring additional support to function effectively. All supervisors must be up to date with equality and diversity training, and that is a GMC requirement. And every equality and diversity training must have reference to the concepts of unconscious bias and differential attainment. Now, these roles are recognised by the GMC, and we all must be up to date with our CPD in foundation training. Next slide, please. Okay, so one of the things that we talk about in the foundation curriculum is the context of the experiential approach and emphasis on the placement supervision group feedback. This is called the Johari window. Some of you may be familiar with it. When we're working, when we're in any environment, there's different things that are relevant to ourselves. So there's an open area, things that I know about myself and things that other people know about me. There are things that I know about myself, but other people don't know about me. And there are things that other people know about me, but I'm not aware of them. And there are things that nobody knows about any of us. Now, feedback from a range of trainers and people helps us increase that open area. So things that I know about myself and things that others tell me will allow me to develop my knowledge, my behaviours, my skills, my communication to improve my performance and my behaviours. So that's why we really focus on feedback, and we focus on feedback through the TAB, that's a team assessment of behaviour, and also the placement supervision group. And we really focus on feedback for trainees rather than what they feel about themselves. Next slide, please. The other thing that we focus on within the curriculum is the learning that trainees do. And we split that into two groups. We split that into core learning and into non-core learning. Now, this hasn't changed from the previous curriculum. However, we have changed some of the syllabus that trainees are required to undertake, and I'll talk about that shortly. So thinking about the number of hours that the trainee is expected to achieve, we're looking for a total of 60 hours of minimum of learning in one training year. And in the 30 hours, we're expected we're expecting the trainees to log the teaching that they have attended based on their foundation curriculum. So this will be the learning that they are delivered in their workplace and is based on their curriculum. It may well also be done as e-learning or watching seminars or webinars, but is focused on their learning for the curriculum. Now, the other 30 hours can come from anything else. Now, this is what they do within their self-development. This may well be through M&M meetings, departmental teaching, seminars, balance groups, Schwartz rounds, all sorts of things that the trainee has the opportunity to attend. And in total, we're expecting the trainee to deliver at least 30 hours of learning. I'll talk a little bit about the syllabus shortly. Next slide, please. And this is the syllabus, this is the core learning. And as you can see, these topics are very high level and they encompass a range of issues, including a real focus on mental health, health promotion, leadership, quality improvement, amongst others. And you can see there are some new topics because we are trying to prepare our doctors for the 21st century. And if you look at the end here, we have guidance on giving learning on the use of genomics and new technologies and the digital agenda. So we're looking at genomics, how trainees will learn about different medications, different techniques that is more tailored to individual patient needs. So this is very much moving forward, and we are trying to prepare those doctors for the future. Now, the curriculum says what's required. It doesn't say how it needs to be delivered. So certain regions may want to do this as face-to-face. They may want to do it by webinars. It's very much up to each region as to decide how this training is delivered, but the training must be delivered to the trainees and it must focus on these high-level topics. Next slide, please. Now, as I said, there's non-core learning, and this is really anything that the doctor wants to do to develop their practice. Now, within the training time, it would be ideal if they had time within their working week as self-development time. And within that self-development time, this might well be online learning, reading any journals that they're doing, attending any study groups, and maybe just reflecting on what they've been doing and writing their reflections. It's not particularly specific. The UKFPO have produced some guidance on what is and what isn't suitable for non-core learning. But the trainees should be encouraged to develop, to widen their knowledge and to focus on things that interest them. Now, self-development time was a requirement specific to the UK Foundation Review. It has been implemented in England, but in the other 3 devolved nations, it is not yet fully embedded in their contracts. So I won't focus on that anymore. Next slide, please. Let's think a little bit about what the trainees need to put into their Eportfolio. So in England, they will be using Horace as normal, and in the devolved nations, they will be using TURAS. The forms that the trainees will be using will be exactly the same, whether they're using the Horace portfolio or the TURAS portfolio, and the assessment will be exactly the same, whichever portfolio they're using. And trainers will be given the opportunity to learn how to complete the forms and how to upload those forms into their portfolio and how to create the links. And I'm not going to go into that level of detail in this webinar. So the trainees need to gather evidence within their portfolio. And I'd like to think a little bit about Miller's Pyramid, which may be familiar to most of you. So Miller's Pyramid considers evidence that the trainees may want to upload, and it adds different weight to different types of evidence. So if we start at the bottom, this is the knowledge that the trainee has, and in fact this isn't just about trainees, this is about any of us. So the knowledge is at the bottom that underpins everything that we do. The next level of evidence, which is stronger, is how we apply that knowledge. And that might be how they reflect on what they may still need to know, what they may need to develop, what their behaviours are, and where they need to go and do further learning. The next level up is the shows how. Can you show me how you can do something? Now that might well be through a simulation, which may be, high fidelity or maybe low fidelity. Both are fine and both are good. Or it may just be talking through something with a trainer. So showing how is demonstrating how you do something, and right at the top of Miller's pyramid is the does. That is what we do in the workplace, and this is what we call experiential learning. This is where the SLEs come in, supervised learning events, and they haven't changed between the old curriculum and the new curriculum. We still very much require the trainees to provide evidence of their experiential learning. The thing with the SLEs is SLEs show that the trainee has the clinical knowledge, that they have the skills to do the procedure or whatever that might be, whether it is an assessment of a patient or whether it's about making up a differential diagnosis, whatever it is, the trainee is showing that they can do it. They're also showing that they have the behaviours, that they have the communication skills, that they have knowledge of the safety, such as sharp safety or infection control, to do that procedure safely, and that they have the correct communication with all the stakeholders, including the patient, their carers and their families. So when we're thinking about evidence, we're looking for the trainee to provide as much experiential knowledge as possible. Therefore, we're asking the trainees to continue to do SLEs and to provide as many of these as they feel is appropriate to link to their curriculum. For example, if we're thinking, I'm an anaesthetist, which I didn't say at the beginning, I'm an anaesthetist, and if I was thinking about how I might want to show my competence in an epidural, for example, so I probably want to upload a piece of evidence to the FPC that says that I know how to do an epidural. So I've done some reading on physiology, I've done some reading on pharmacology and anatomy, and I know that, so I might want to upload that. I would then upload some knowledge to say that I've reflected on it. What else do I need to know? Do I feel I have the skills? Do I feel I have the knowledge? Then I might have done it on a simulator. I might have done it on a simulated back to show somebody else that I have the skills to do that. And then right at the top, I would want to do an SLE. I'd want to be assessed by one of my colleagues who would watch me perform an epidural on a patient. That would encompass everything. It would encompass my clinical skills, my communication, my safety, for both infection control and sharp safety. It would focus very much on how I do something. So I would want to provide all that evidence for each FPC that was relevant. So for the clinical FPCs, so for HLO1, which is an accountable, capable and compassionate clinician, what we'd be hoping that the trainee would do would provide an SLE for an interaction, that they may have done some simulation in it, that they have some reflection, and that they have the knowledge. So that's how we expect trainees to link to the FPCs, particularly for FPCs that link to HLO1. We also want to see that they have parity of mental and physical health. So perhaps if I was looking to see what I would do for mental health, I may consider somebody who has an acute delirium or say a withdrawal from a substance that they were dependent on. I would then perhaps do an SLE doing a mini KEX on my assessment and my management of that patient. I might have done this in simulation. I might have had a session on how to manage a patient who was confused. And I would need to upload some evidence on that I knew about withdrawal protocols and the causes. So as you can see, for each FPC, we're looking for physical health, mental health, and a range of pieces of evidence to underpin that. For HLO2, we're looking for more evidence of how valuable you are in the healthcare team. So that's where we're looking for evidence such as the TAB, which is the team assessment of behaviour, and any feedback that the trainee gets. And for the professional HLO3, we're looking at how they've developed their portfolio and how they have attended their teaching and how they have progressed within their portfolio development. This is where I see a challenge because this is very different from previous curricula and assessment, where we have asked for a specific number. We have been very didactic and specific and said you must do 5 SLEs per post in order to complete or arrange. But actually this time we're saying we want full curriculum coverage. The trainees aren't going to be allowed to link any more than 10 pieces of evidence to each FPC because we don't want them overburdening themselves and we don't want over-assessment. So there is no specific minimum as long as they show a full range of evidence for each of the FPCs. Thank you. Next slide, please. Okay, this just shows how the curriculum fits together and everything goes into the Eportfolio. We need to see their SLEs. We need to see their multi-source feedback in the form of tabs. We need to see the feedback from the placement supervision group and the supervisors reports, both the clinical supervisors reports, which is only 3, and their educational supervisors report. We want to see their learning, both delivered and also self-development. And the supervisor, the educational supervisor, should be reviewing their portfolio regularly to make sure that this is progressing. What we don't want to see is the trainee who starts this the day before their evidence is required to be submitted because it's far too much. The education supervisor should be reviewing this portfolio on a regular basis with the trainee to make sure that they are on track to meet the requirements at the end of the training year. Next slide, please. Okay, let's talk a little bit more about assessment. Thank you. One of the things that the new curriculum talks about is the difference between formative assessment and summative assessment. So summative assessment is pass-fail. It's you're either okay or you're not okay to progress. And the summative assessments in the curriculum are the clinical supervisors reports, the educational supervisors reports, and for the F1s, the prescribing safety assessments. Now, how do we use our formative assessments? So formative assessments are learning events, and these all pull together and provide evidence of whether the trainee doctor, the foundation doctor, is satisfactory or not. And I like to think of the clinical supervisor's report as saying, is this doctor working at the correct level as a foundation doctor? So are they performing as an F1, that I would at the standard of an F1 in my unit, or are they performing at the level of an F2 in my unit? If the answer is yes, and the feedback comes from the clinicians and the rest of the multidisciplinary team supporting that foundation doctor, then they will have a satisfactory clinical supervisor's report. If that is not satisfactory, then they would potentially need further training depending on your deanery and schools processes. They will also need a satisfactory educational supervisor report, and that is whether they're meeting their educational requirements. So the educational supervisor will be looking at, have they mapped to the curriculum? Have they met all the HLOs? Have they provided the right form of evidence? Have they got their feedback? And have they linked to their curriculum? So that's what the educational supervisor should be doing. Now, the new assessments that we've introduced that are now mandatory within the foundation curriculum is a summary narrative, and I'll talk a little bit about that, and the placement supervision group form, which has been in existence for quite some time, and we're now going to be asking for one of those as evidence of HLO2 and HLO1 in some places. Next slide, please. Okay, so this slide just shows which bit fits into which bit really. So as I've just said, the clinical supervisor assesses the foundation doctor's performance and takes information from the team, and the education supervisor looks at the curriculum, the evidence of learning, and all the evidence that the trainee submits into their curriculum. They come together and all this is submitted to the ARCP panel. And at the ARCP panel, they review all the reports and the evidence that the trainee has provided, and make an assessment of whether that trainee is ready to progress from F1 into F2, or from F2 to exit the programme and be ready for specialist or general practice training. Next slide, please. So one of the things that we're going to be asked, and we have been asked, is what are the changes? And the changes between the curriculum 2016 and the 2021 curriculum is that we have tried to reduce the burden of assessment. We heard that the trainees were struggling to try and achieve a huge number of SLEs, and this was tiring them out. And we want to reduce the assessment burden. However, we want to ensure that they're adequately assessed, and that's where the challenge lies. So we're asking the foundation doctor to be quite selective about how they link their evidence. We don't want for each HLO, for each FPC, for them to put in 20 pieces of evidence, pile everything in, overstuff their portfolios. We want them to be selective and think about what they're uploading. We haven't got a minimum number of SLEs, and this is going to be a challenge for people because we've been very specific in the past and very didactic about how many SLEs we've asked for. We're not going to do that. However, in order to fully evidence the curriculum, the trainee is going to have to do a good number of SLEs, probably somewhere in the region of 12 to 15 SLEs over the training year, if not more, but we're not going to mandate a specific number. The other thing that we have been very specific about is the parity of evidence of physical and mental health. A trainee who has nothing in their portfolio about mental health, both acute and chronic mental health problems, will not be able to complete their foundation training curriculum that year, and will be asked to provide further evidence of mental health training. We also want to see some understanding of social health, because all three are very, as you know, closely linked. These are the main changes. The other big change is that we are not going to require any specific life support courses. For example, an ALS or an ILS course. Now, the course will not be mandatory. However, the competencies will be mandatory. So the outcomes and the competencies of an ALS course and an ILS course will remain within the curriculum, and the trainee will need to evidence them, but they don't need to evidence them by a specific ALS or ILS course. It may well be that they do choose to do an ALS course or an ILS course, and the foundation school or organisation may choose to ask them to complete it in that way, but the actual specific course will not be the requirement. The other thing that is different this year is the introduction of the summary narrative, and I'll talk a little bit about that shortly. Next slide, please. So within the curriculum, we have provided a blueprint of assessments, just to remind everybody, both the trainee and the trainer, as to what kind of evidence they should be linking to evidence each of the HLOs. And I'm not going to talk about this in any detail. It's all within the curriculum and on the UK FPO website. Next slide, please. So as I said, we are very much focusing on generic training. We want the doctors to move from year 1 into year 2 to revisit the portfolio, to revisit it and to demonstrate the different behaviours within from F1 into F2. Next slide, please. Okay, before I complete, I just want to talk a little bit about the summary narrative. So the summary narrative is essentially a short 300-word statement, paragraph by the foundation doctor that they will build on between the beginning of their training year and the end of the training year. For those of you who have appraisal, regular appraisal, you know that you have to provide a statement or some prose to demonstrate your evidence of the GMC capabilities. So what we're asking the foundation doctor to do is to write a 300-word narrative that essentially explains why they have selected the evidence that they have done. We're expecting 3, one for each of the HLOs, and we don't want them to write pages and pages, just a few short words about what they've done, why they've selected the evidence, and why that they feel that they are ready to have these HLOs completed. This is done in many specialties, so general practice use this, mental health uses this, and paediatrics, and I'm not sure about any of the other specialties. I haven't looked in detail, but this is very much the way of the future, and the purpose of this is to train the foundation doctor for the future about selecting their evidence and becoming lifelong learners. They will need a lot of support with this, and as trainers we're going to have to help guide them with the content of their summary narrative. So that's something that's new and will require some thought from all of us. I'm going to close this talk just now, and I will take some questions. And I'd just like to signpost everybody to the UKFPO website, where there is much information on the curriculum, the 2021 curriculum. There are a series of webinars, of which this is one, and there are podcasts on the specifics, such as the PSG, the summary narrative, how to build a portfolio, and I would strongly commend you to go and peruse the UKFPO curriculum 2021 curriculum page and sample these podcasts and documents that coexist with them. I'm going to close there and thank you very much for listening, and I shall take some questions now. So thank you. Okay, so I have some questions here. So I've got a question. It says HLO2 seems to be dependent in part on the approach of the team the doctor is operating in. Have you a sense of how nursing staff will be engaged with this? I think HLO2 is very much about the team, and in my experience, the nursing staff are usually very engaged with this. I think having written feedback through the TAB and through the PSG is already happening in many areas. And I think some of the nursing staff will perhaps need a little bit of support and encouragement, but certainly in where I work, the nursing staff are very happy to engage and to formalise their comments about the foundation doctors. After all, the nursing staff work incredibly closely with the foundation doctors. I hope that answers your question. I think it's incumbent on the clinical supervisors to have a discussion with their nursing staff, with their senior nursing staff, and their senior pharmacists on the wards and in clinical practice and general practice to support them and encourage them with this. I hope that's answered your question. The next question is, do I need another curriculum update after attending this webinar? would strongly advise you to have a look on the UKFPO website and look at all the other podcasts and webinars that have been recorded and are available. Your local foundation programme director, your FTPD or your foundation school director are very likely to be running local sessions for you. And certainly if there's any questions, then you can submit to the UKFPO for further advice. So I don't think this is not everything that you need to know, but it's certainly an overview of everything. So I would strongly commend looking at the other podcasts and specific webinars that have been recorded on the UKFPO website. Okay, I'm not sure I'm going to be particularly good at answering the next question. I find it very difficult to get response from the PSG. Any tips? That's an interesting one. I would suggest just constant encouragement from my colleagues, and also a reminder about how valuable it is to the trainees to get feedback in the PSG. We've also mandated it. I think once you mandate something, it makes it much easier to get a response from your colleagues to do this. Now, when we spoke to the trainees for the foundation doctors about feedback, what they told us was that TAB tells us if they are nice people. So it tells them if they answer their page, if they're accessible, if they communicate well, whereas the PSG tells them that they're good doctors because it comments on the 4 domains of good medical practice from the GMC. It focuses on their clinical skills, their communication, and their quality and safety, and they're working as a team. So actually what the foundation doctor likes is feedback from their seniors that tells them that they are good doctors or where they need to develop. So I think it's incredibly important, and I think it will embed, as it now is a mandatory requirement to have one PSG. I think it will drive engagement. The next question is I've probably answered that one. How important is the PSG feedback? I think I've answered that, and we heard very strongly from the foundation doctors that they really like the PSG feedback. They love to be told that they're good doctors, and specifically, do they have good clinical skills? Are they good at what they do? And it's more than just whether they're accessible and whether they're polite and good communicators. And we have strong evidence that the PSG feedback has been more specific about issues, about competence issues, about concerns than the TAB has picked up. And there's a specific paper which actually states that in trainees who have had TABs that have had no concerns on them, there have been concerns raised within the PSG that have actually been really important for the trainees' progress. So I would say yes, the PSG is very important. That feedback, again, from the Johari window about learning about themselves, but also in identifying problems in the trainee. So I think it is important, which is why we have made it mandatory to have that feedback as a way of evidencing their portfolios. Now, the next question is, when will the summary narrative form be available in Horus? My understanding from Kata, who is a UKFPO policy officer, is that all the forms have been published and available on Horus from now, so it should be available. Next question is related to summary narratives. The summary narrative podcast is available on the UKFPO website, and there is a fact sheet that goes alongside it. We will publish some examples of summary narratives that can be used, but can be used as ideas for trainees and for trainers as how they want to develop them. I'm not particularly keen to provide sort of template summary narratives so that they're not just kind of produced as this is a standard good quality summary narrative, because it really is very much what the trainee wants to write. It's not a specific form of words, so it's really what the trainee wants to write, because each trainee will have provided different evidence and they might want to share it in a different way. So we will provide some published suggestions. Next question, well, this is an interesting question. When can we expect protected self-development time for FYs in Scotland to be mandatory? I work in Scotland, as I'm sure most of you have probably worked out. It's very much dependent on our contract and on engaging with the DMEs, the medical directors, and Scottish Government to fund it within their jobs. So I can't give you a time frame, but what I would say to you is that the foundation school and the Dean are working very closely with the DMEs and Scottish Government to try and get this embedded as a mandatory requirement in the foundation contract in Scotland, but we're not there yet, I'm afraid. Next question is again about the PSG. So this question says, how do we select members for the PSG? Is it only staff they are working with in the current post, or does it need to be a wider group for across the year? So the PSG is meant to be done within one post. So it's actually, so what we'd be expecting the clinical supervisor to do at the beginning of the post is to identify the members of the PSG for that particular post that the trainee is working in, and send it out towards the end of that post to gather that information. So it's not for the whole year. We're expecting a requirement of one PSG to be one satisfactory PSG per year and per training year. But of course, if there are any concerns identified, then we can ask for more than one PSG. The other thing to remember is that within the PSG, there are little boxes where you can write where, or not you, but certainly your colleagues can write where they felt that the trainee is working above the level expected. So it's got a box that says, as well as concerns, comment on areas of excellence. And again, this is something, as you can imagine, that the trainees love to have information written in their portfolios about areas that they're really good at. So it's not the wider group, it's one post, but it can be done several times. And in fact, in some posts, for example, in general practice, where the number of trainers is quite small, the supervisor may think that they probably need time to do another PSG to widen the range of assessors. So I need to just go a little bit here. Okay, so I haven't mentioned foundation peer mentoring and foundation self-development. So foundation self-development time is not directly in itself related to the curriculum. We're expecting self-development time to be delivered in England and the other devolved nations. It's not yet fully embedded in, and we're expecting trainees in England to have, I think it's 2 hours in F2 per week of self-development time. But as I work in Scotland, I'm not fully aware of exactly the detail of how this is delivered in England. Again, foundation peer mentoring. There are suggestions on the UKFPO website as to how peer mentoring should be supported. But again, it's not something that's recorded within the curriculum. But it's certainly something that is developing. The next question is a question about ARC-P. So ARCP assessment takes place at the beginning of June, and hence there's no time to get the PSG for the last group of F2 trainees. Yes, absolutely, I agree. So we haven't been specific about this, but we would strongly advise that the PSG takes place in either post 1 or post 2, because if there are any requirements that the trainee has not met, so if there's any areas that have got some concern or major concern, then the trainee needs an opportunity to rectify that. They need, if they have an unsatisfactory PSG in post 1, then they've got post 2 and possibly some of post 3 to get information back to say that they have addressed those concerns and they're now working at the correct level. If it's only done in post 3, then they've got no time to remedy that. So I would strongly advise doing a PSG in post 3 as their first PSG. We haven't been that specific within the curriculum because it is very general, and this is the sort of training that and discussions that will be had within each foundation school as to how they want to do this. But certainly the foundation school directors would be very keen that PSGs and tabs are done early on in the training year rather than at the end of the training year. Next question. That you could have 3 PSGs. Yes, you could. You could have 3 PSGs per year, but it would be very much up to the foundation education supervisor and clinical supervisor to see that if they actually required that. Next question is again about the PSG. Is there any minimum limit? And we have not put a limit on that. On the number of people, because again, different units have different numbers of people, particularly in general practice where there's often not many people that will contribute to the PSG. However, the PSG will be incredibly valuable in general practice, but we may well want to increase the number by repeating a PSG, not to invalidate the one in general practice, but just to build on it and give a wider number of respondents. The next question is about how do the trainee document their summary narrative. It's done on Horus and on TURAS, so there is a form within both portfolios that the trainee can open, and they record their summary narrative on this form, which is then uploaded into the HLOs and available for the supervisors, the education supervisors, to review. I think we have come to the end of the questions. I'm happy to stay on for a minute or two longer if there's any other questions. But I'm delighted that there's been so many questions and interest in the UK 2021 Foundation Programme curriculum. Another question on the PSGs. Can we do 2 PSGs in a year? Yes. You can do 2, you can do 3. It's very much up to the education supervisors, the clinical supervisors, to get that information. The requirement is one satisfactory PSG per year, but you can have as many as you wish. It's also good for getting positive feedback for trainees. If they've got good feedback, or they've done something particularly good, they want to have that in their portfolio, so that it's not just about recording concerns, it's about recording excellence as well. And the trainees like, as you can imagine, the trainees like that too. They like to have something positive. So yes, absolutely, you can do several PSGs in the training year, but I really would caution against doing the last one, doing one PSG in the last post, because there is no chance for the trainee to be able to reflect and develop. Last question, I think, could locum or retired consultants be F1 supervisors? As long as they have, the answer is yes, as long as they have ROT, recognised trainer status from the GMC. That's very much a local arrangement in each foundation school, and the governance around being an educational clinical supervisor is the responsibility ultimately of the GMC, because it's a recognised post, but in different areas recognise trainers in different ways, but you must have recognition of trainers status to be a supervisor. Last question, I think, on the PSG, I think I've probably answered it. We haven't mandated whether so the question is, do you anticipate the PSG to be carried out in a particular month, 4-month block, first or second? I think yes. I think the sensible thing is to do it in post 1 or 2, or post 3 and 4 if you're sorry, post 4 and 5 if you're thinking of F2, so that the trainee has a chance to reflect and to remediate. And then you would repeat it to show that everything had been resolved and there were no longer any concerns. So I'm happy to stay on for another couple of minutes, or we can close the session now if there are no other questions. And again, I would like to thank everybody for attending this session, and signpost everybody to the UKFPO website, where there is further information, more detail on the summary narrative, more detail on the PSG, more detail on how to undertake SLEs, and how to build your portfolio. So there are a series of podcasts, webinars, recordings, and fact sheets that will guide you. Also, a good source of information is your Foundation School Director, because they are all fully aware of the Foundation Programme curriculum and the assessment process. And your Foundation TPDs will also be fully trained in it. And of course, in England, if you contact any of your deans or associate deans, in Scotland you have associate postgraduate deans and Foundation School Director. Wales and Northern Ireland have Foundation School Directors and Deans as well. So we are all fully conversant in the UKFPO 2021 curriculum. So there's a huge source of information out there for you. And thank you very much for listening and attending tonight. I hope you have a lovely evening and enjoy the sunshine.